Okay, we should be live just about now. Just takes a second to kind of come through. We should be live. Perfect. So good evening, everybody. Thank you for joining us for the final Lipedema World Alliance live stream for Lipedema Awareness Month. We are delighted to welcome you to a really fabulous panel discussion this evening. I'm Kate Forster, one of the board members with the Lipedema World Alliance, and I'm joined tonight by 4 of my board colleagues, and I will get them all to introduce themselves in a moment. We are particularly keen to talk about the use of GLP-1 receptor agonist medication in lipedema because we recognise there's a lot of interest in it, both in the patient community and in healthcare professionals and in research. And we're probably at that stage when we've all got more questions than we have answers, but we're going to do our best tonight to discuss a range of perspectives on some of those questions and on how GLP-1 receptor agonist medication might fit with some of the other tools and techniques that we have available for managing lipedema and contrasting it in that context with other interventions, which I think is particularly helpful. Because this is a live stream, we encourage you to participate by posting comments and questions in the chat box, which is on the right-hand side of your window, or underneath it if you are watching on your phone. And you will also find that anything that you need to ask, you can pop it in the chat and we will be able to help and assist, hopefully, as we go through. So just what I'm going to do, I think, is I'm going to ask the rest of the panel to introduce themselves. So may I ask you, Tom, to start us off, introduce yourself, and then we'll go around.
Hi, yeah, so I'm Thomas Wright, and I'm a lipedema surgeon, researcher, and student of lipedema. That's and happy to be on the program today.
Tom, we're delighted to have you here from America making time for us in the middle of your morning, along with 7 of us here from Europe. Gabriele, did you want to introduce yourself next?
Hi, thank you very much, Kate, for the introduction. I'm Gabriele Faerber. I'm a GP. I'm a phlebologist and lymphologist, and I've taken a special interest in lipedema. I can't remember how long, but I think since 2008 or something, especially in combination with nutrition, which is sort of my part tonight, probably, because my experience is far wider in the field of nutrition than in the field of GLP-1 RAs, although I have some. So I look forward to the discussion.
Thank you. Manuel, would you introduce yourself?
Thank you, Kate. I'm happy to be with this webinar today here, and I'm a dermatologist coming from Germany, Düsseldorf. My favorite things are lymphology, and I'm familiar with lipedema since 1992, specialized in clinical investigations, in studies, in guidelines, and in surgery, which is for me the most and best therapy on this disease for everybody in every stage. So I'm very interested in listening to all these discussions today and giving my views and points, as well to the question of the coincident obesity, which is quite often familiar with these lipedema ladies. Thank you.
Thank you, Manuel. And last but not ever least, Jose, would you introduce yourself and explain your practice?
Okay, good afternoon to everybody. Good morning in United States. I'm Dr. Simarro. I am a specialist in aesthetic medicine, but I'm also graduate in university in nutrition. And I have been trying for a long time to join nutrition and medicine. And the earliest, in the beginning of this century, in 2007, I founded the Lipedema Institute, because in my practice as nutritionist and doctor, I have seen that some patients didn't lose weight with the normal diets, and they have something different. And I studied that, and I found it was lipedema. Then I found the Lipedema Institute that has been investigating the lipedema by its clinic point of view. We have developed a new treatment that will be in a clinical assay the next year. But at the moment, what we do is clinical investigation of lipedema and in diagnosis of lipedema.
Thank you. I'm really lucky to be joined by such a great spread of opinions and perspectives. So, Tom, would you start us off by giving us a bit of a context around the topic of GLP-1 receptor agonists and take us into how they are used in lipedema and your own perspective on it, please? Thank you.
Great, great. And again, thank you for the opportunity. So yeah, that's, I'm going to go into the, back up one. So like this all started, like many insights in clinical medicine, started with patient experiences. And this is a lipedema patient who noticed that 3 days after starting the GLP-1s, that her swelling greatly improved. And so she was suffering with a spiral fracture, and then started the GLP-1s, and that immediately had noticed decreased swelling. And then she was stopped her GLP-1 prior to surgery, and a lipedema surgery, and then just when she restarted it again, significantly helped her swelling. So that's sort of where that got me to thinking about, are these medicines that we're so familiar with in terms of their weight loss and diabetes, or do they also could they possibly also treat lipedema? So let's kind of just first a little background and review the mechanisms of actions. So I mean, these medications have profound effects on just about every cell line. In the brain, they affect appetite. So they are two of the most powerful appetite suppressing hormones. So there's others. There's about 7 or 8 hormones that suppress appetite, and there's one that stimulates hunger, ghrelin. But the GLP-1 and GIP are to our knowledge, some of the more potent suppressors of appetite. And then they affect pretty much every organ. I'm going to skip over the heart because we're going to go in that a little bit more. But they affect the pancreas, and they lead to new beta cell formation. They increase glucose uptake in the muscles. They have effect on the endothelium-dependent vasodilation, natriuresis in the kidney, increased lipolysis in fat cells, as well as glucose uptake, and decreased GI motility. And we're going to touch on all these, as well as its effect in the liver. So GIP is another one of these, is in a combination. Mounjaro, Zepbound, tirzepatide is also blocks GIP, and so that GIP stimulates brain cell proliferation. It actually causes increased adipose tissue creation and increased bone formation. So we know its effect on, I mean, these are well known to have the effect on diabetes management and decreasing glucose and decreasing glucagon release, as well as the touched on satiety. But they also increase brown fat activity, increase adiponectin, and decreased adipocyte or TNF alpha, and improve mitochondrial function, and improve adipocyte differentiation. So again, just very briefly touching on their effects, they've been shown to result in about a 15 to 20% weight loss in people overweight who are overweight. Now, drilling down a little bit on the effects on the heart, they improve myocardial contractility, improve coronary blood flow, decrease cardiovascular events and cerebral events. They have the antioxidant effects through decreased oxidative stress and improving endothelial function. They have anti-inflammatory effects, again, through TNF alpha and IL-6, and that overall improves cardiovascular health. And then they cause fibrosis and lipolysis in epicardial fat, and which is a known cardiovascular risk factor. In the liver, they've been shown to reduce hepatic fat deposition and decrease fibrosis in the liver. So these medications have side effects. In fact, almost everybody experiences side effects on these medications. They are generally self-limited. In other words, they generally are at the beginning of when starting a medication, and then they abate after people have been on the medicine for a time. Nausea is, almost everyone is going to have some nausea, often vomiting, diarrhea. They can also cause constipation, and severe reactions occur, and they're not exactly rare. Pancreatitis can occur, cholecystitis. And there's been some concerns about thyroid tumors, though I will, if we get a question about that, I'll get more into that. So could they possibly be help lipedema itself? Obviously, weight loss helps people with lipedema who are overweight. Weight loss is going to help their overall health, but they do have positive effects on all sorts of metabolic factors, including not just blood sugar, but also triglyceride fatty metabolism, and improve hormone sensitivities, and then anti-inflammatory effects on fibrosis. And I'm going to another slide about that. So we do see increased fertility in women on GLP-1s, and this is speculation that it's possible that we're also seeing increased sensitivities in rebalancing of, say, the alpha and beta receptor in estrogen receptors in women with lipedema. It's possible. And it's also possible that they could have, they can affect epicardial fat. They could affect lipedema fat and induce lipolysis. They are known to upregulation of UCP, uncoupling protein 1, which increases thermogenesis. And as Dr. Herbst has noted, the lipedema tissue tends to be relatively cooler and less thermogenic. At least that's a clinical observation. And they could they could and help extracellular matrix regulation. So that's sort of the background. So I undertook a study. This is really just a very small pilot study. I think I have complete data on about 12 women with lipedema on GLP-1s, and most of them were the tirzepatide. And we assessed them with bioimpedance, and then we followed pain ratings and swelling, some promised global health things, and some metabolic markers of inflammation. And in these lipedema ladies, they averaged, again, this is a shorter thing. This is about looking at about 3 months of use. They averaged about an 8% weight loss. The other weight loss studies were longer and showed more weight loss, at least outside of lipedema. And that was statistically significant. They also had about an 8% decrease in subcutaneous fat. And the more striking 10% decrease in visceral fat. Now so when you lose weight and more of that weight is fat mass, you're going to increase your muscle mass. And so they did increase their muscle, their percent of muscle mass, and about 4%. But that did not reach statistical significance. Just the p value was 0.18. And then they did reported decreased tenderness to touch. So it went from 4.8 to 4.0. And that was, I mean, significant at the p01, again, for this small pilot study. And the swelling, they reported less swelling. And I'm going to at least 6 weeks they were reporting decreased swelling from 5.8 to about 4 on the scale of 1 to 10. So basically looking at swelling after exercise, leg pain, and leg pain after exercise, they showed modest and either nearly significant or significant changes in these symptoms. So in summary, in addition to the glucose things, they have improved cardiovascular health and hepatic health, and lipedema patients have reported decreased swelling and tenderness to touch. And so far in this small study, small and shorter study, we are seeing weight loss, decrease in sub-Q fat, decrease in visceral fat, and a non-significant change in percent of skeletal muscle mass. So these early observations show there's some promising effects in women with lipedema. Again, this is early, and I wouldn't use this as unrefutable evidence, but it does suggest that more study is needed to see if this is a possible medical treatment for lipedema. And that's, we really, we have these dietary measures, but we really don't, and compression, but we really don't have a medicine at this time that we can say for sure helps lipedema. So it's certainly worth investigating.
Thank you, Tom, for introducing that for us. It's an awful lot of kind of questions I'm sure that it's brought up for all of us. So thank you. And we've already started some discussion in the chat. So before we start looking at some of the comments we have in the chat, I'd like to just get perhaps some thoughts from the other members of the panel on your presentation. So I don't know who's perhaps got any particular points they'd like to draw on in what Tom was talking about in his own patients. So if anybody would particularly like to jump in, please do.
I've just got a question. You said visceral fat and subcutaneous fat decreased. How did you measure it?
Oh yeah, bioimpedance. Yeah, yeah. I did. I think I didn't. Did I not include that slide? But we did look at we followed them with bioimpedance.
The bioimpedance was impedancia of the 5 cylinders, bioimpedancia of the hands, of the arms, bioimpedancia of the legs, and bioimpedance different, not from all the body.
So no, so that was overall body bioimpedance. We could segmentally look at that as well, but yeah.
There's no scientific proof that segmental measurement helps.
Segmental, yes, that's very important.
No, I don't. I mean, as far as I know, there's no scientific proof that you can really do segmental measurements.
I think you look like you want to jump in, Manuel. Would you like to jump in at this point? Oh, you're muted, so we'll miss your wonderful words.
Sorry.
Perfect.
Stupid. Thank you very much for the presentation. There's an interesting question, and you do the work. I'm always happy when someone goes on with like you do it, asking questions and looking what are the answers. So just one question from me. Reporting on the symptoms on the legs. Did you see any symptoms changes as well in the arms? Because you started with a young lady with a post-surgical treatment edema situation after a spiral fracture. Then you showed us that these edema were fading, and then you told us that she had a severe lipedema. It was always the arms, I understood. So in all your presentations, you are focusing on the legs. Did you as well measure the arms? And are there any effects on the lipedema arms on these ladies?
Well, that is a great question,
Thank you.
Dr. Cornely. Especially because we did actually ask mostly about the legs, even though the original insight was from the arms, because I was looking and trying to keep it as simple as possible, and I was hoping that it would be, I would see more of a difference in the legs, and that's what we looked at. Yeah.
But what is your clinical experience? Do you think there's something working just for the legs, or do you think it works as well for the arms? What is your idea?
I think it helps both legs and arms.
Okay.
For sure.
So we would love to see that it helps both. So you will allow me next question again. And this last paper, you showed the effects. I opened it here on my screen. The effects of lipedema and lymphedema. You showed us that it was symptoms before and after tilzepatide. What means after? How long do you give this medicament, and then you stopped and you showed it directly after, and then you had a post-treatment investigation a few months later, or what do you give us?
I'm not exactly sure which. I think you're referring to the slide about pain and tenderness after exercise. So we'd also heard reports from our patients that they were not only were they feeling decreased tenderness, but they're after exercise, which is normally a time when they have increased tenderness, that they were having even more relief of that, and it basically looked like before and after exercise both they had decreased.
So sorry, it's not after the treatment with the medicament, but it's, I didn't understand. Do you treat them for a special time, then you stop?
Oh, right. Yeah.
Then you had the first investigation, then you had a second after a few weeks or later, and can show us what happens when they stop with this medicament.
Oh, yeah, I don't have good data on that.
Okay.
So some have continued on, and some It's really kind of it's a non-controlled study, so some have persisted, but I think that's a great thing that we should look at whether these symptoms return after they stop the medicine.
Thank you. Last question, Kate. I know you gave me a sign. This is the most important thing because these medicaments are forward not to take them for the rest of the life. We are interested in the effects on obesity. We know those. They are best investigated. We do not discuss this. We know the effects on diabetes. That's all clear. What we not to know is has it any effects, not the side effects, the effects in lipedema patients on legs and arms if they just take it for a short time or have to take that a long time. And I'm not really interested just in the question, does it lose the weight? I'm interested to what changes are in the symptoms. And the symptoms is, as you know, the pain. That's the most important. So it's really necessary to know when you take it for a time, you stop it, and then you have a new investigation a few weeks or a month later, during what's with the weight and what's with the lipidema. Thank you.
Great, thank you.
Oh, did you want to come back on that, Tom, just before Jose jumps in?
No, I think those are great points, and they it should be looked at. And I can't tell you. My suspicion is that these improvements they notice are likely going to go away when they get off the medicine, just from that one patient who stopped it and then had the swelling, and so I suspect if I look at that I will find that this improvements in pain and swelling they are reporting likely will dissipate when they stop the medicine.
Did you want to jump in, Jose, and then I'll go after you?
Yes. First of all, I want to make a statement. What we're speaking about, there are not any clinical conclusions and nothing published about treatment of lipedema with GLP-1 agonists. So, somebody told me before, there's not a clinical study. There's not a clinical study at this moment about this. So what we now are speaking is about our clinical experience, not about nothing published. So if somebody says there's no clinical demonstration, of course, but no me and no other. What we are just speaking is about our clinical experience and about what we think, because it's completely different, for me at least, the experience with obese people than with lipodermatous people. I think we are speaking about our clinical experience. No, it's not scientific, and we have to have this very clear. Thank you.
Yeah, I think you're right. That's certainly why this was a challenging discussion for all of us to put on, that we're comparing a limited amount of clinical data. And I think, Tom, you described that very well. So I will say we have had someone asking in the chat, you've presented some clinical patient experience for us tonight. Is it something you're putting together to publish? Because they're interested in kind of where you are on publishing on this topic. Would you speak to that for a moment?
Yes. Well, yes, I'm having, I've sent the data to be checked and analyzed, and with the hopes of publishing it is my plan. I have no,
I think we look forward to, in that case, as members of the Lipedema World Alliance, talking about your paper when you publish it. And people will probably need to be patient some time for that.
Yes, that is not necessarily an easy task.
Manuel, jump in.
Tom,
to my list.
Thank you. I'm glad when you publish the papers so we can read all the data again and analyze them better than just listening to the demonstration today. Are you going? I know you have an office with lipedema patients. How do you decide if a patient has the right conditions to get such a stuff, and do you give them to them? And how many patients are in your office which are treated with this medicament?
So there's multiple parts to that. So first of all, I do offer it to those who are having symptoms who, so first we start with the anti-inflammatory low carb diet in compression. Those are the cornerstones, and for those who are still having symptoms on that, then we offer that as an option. Now, some get it. I do prescribe it, as well as some of them get it elsewhere from other doctors. And in the U.S., you can pretty much just get it online, through. But so then, yeah, now I am more likely to offer to those who are either overweight and struggling, and I trying to get them optimized if they're either before or after surgery, and then yeah.
So your indication is not lipedema, your indication is overweight.
No, I do offer it to non-overweight patients who have, and that's, and for them, I'm using a lower dose. I use a lower dose, and I don't escalate the dose. And I'm just titrating it to see if it'll help their lipedema symptoms.
Do you use this cornerstone diet as well, for example, in stage 1 lipedema patients?
I do. I tell even my stage 1 about avoiding the refined carbs and highly processed foods, because I think it helps everybody's lipedema symptoms.
Do you see effects? Sorry, Gabriele. Do you see effects in the pain, the symptom, in these stage 1 patients which have no obesity?
Again, this is anecdotal, just in clinical experience.
Sure.
I've had them report that helps their symptoms. Yes.
Okay.
Even stage 1.
I'm going to press the pause button on Manuel
Sorry.
in a second. You're good. I will let Gabriele come in 1 second. Tom, did you just want to finish talking to us about prescribing? Because we'd had a couple of questions around whether this was effectively on or off label for patients who don't have, say, a BMI of 30. And I'm not familiar with all the criteria for prescription in the US, but
this is completely off label. There's no indication.
My assumption.
There is no indication for the for GLP-1s in the treatment of lipedema.
Yeah. So if a patient has obesity as well, or if we reframe it, if a patient has a BMI that falls within, for example, the definition of obesity, so it's mostly, I think, in most places around a BMI 30 that's linked to on-label prescription for GLP-1 receptor agonists, they would be able to receive it as an obesity medication. But where you're prescribing it for patients, so you will prescribe it for patients at a lower BMI based on your overall clinical experience with them. And where you're prescribing it, you said it fits in after other tools and techniques like managing ways of eating, and then you're prescribing it in a slightly different way.
Yes, yeah, exactly. Exactly. And we use doctors all over the world, but certainly in the US use the medications as off-label.
Yeah, for sure. It's just because people are trying to understand whether there are different prescribing criteria, and anywhere it's on label for lipedema. I want us just to try and walk through some of this slightly logically. I do have some other questions, but I'm going to hand over to Gabriele for a second and let her come in. Gabriele?
Tom, you mentioned very briefly that you use them on all sort of stages of lipedema. What I wanted to know is, do you accompany the treatment with nutritional advice or lifestyle, because a few days ago I found a sort of nutritional advisory published by 4 American institutions of obesity, College of Lifestyle Medicine, Nutrition, Obesity Medicine Association, and so on. And I found it very interesting and very commendable what they wrote. It is bad medicine and economic insanity to prescribe those for obesity without comprehensive program of nutrition and lifestyle. And they stress the point that the add-on is the medication, not the other way around. Yeah. In most cases, the patients receive the medication, and if they are lucky, most of them are not, they then are given nutritional advice a little bit on the side. So what was your procedure in that way?
I agree completely with this obesity medicine, and because I think it should, they are an additive or a help on top of the diet and nutrition, because they and again, it's insanity to not use these to help help with people. Everybody needs help eating better, and these allow people to make changes to improve in their diet, and so yeah.
Thank you, Tom. So you're starting to talk a little bit about where in your clinical experience the medication fits and where you'll prescribe it. Have you, the patients you presented on tonight, you said at least one of them had stopped the medication for their own reasons. Do you have any comments on perhaps we've had a question asked of us, which is, would it be appropriate to prescribe GLP-1 RA medication at a low dosage in the long term? And we've started to have a little bit of a discussion, I think, in this group tonight about what happens if people stop taking it. So would you comment on your views about the medication being used long term and what that might mean? And then I'd be interested in some comments from the others on that.
Well, I mean, I think they can be used long term. Ideally, they're used for a shorter term and at the lowest dose possible. That's my feelings. But I do believe, and we have, over a decade. Really, if you go back to some GLP-1s, we have almost 20 years worth of data, and there's people that been on them for many years without. So I think they can be. Again, I think always for the lowest dose for the shortest amount of time would be ideal for, I think, everybody.
And those patients who've been prescribed them for around 20 years, if I'm right, Tom, that's frequently for patients where the prescription was based on them having type 2 diabetes, for example. So it's for the other prescribing reasons, which are potentially long term. Is that correct?
That's right. Yeah. And
so we have safety data for 20 years, maybe, is your point.
Yeah, exactly. Yeah.
As opposed to this. I do have a question, if you will indulge me, which is taking us a little bit off topic, but I'm sure everyone will forgive me as I've started. Your patients that you were telling us about, Tom, you mentioned that they had reduced swelling, and I know we discussed the bioimpedance, but were you carrying out like limb volume measurements on the patients for that swelling reduction, or was it a subjective patient feedback? I know that's something people want to understand when we talk about changes to limb volume in lipedema patients.
That's a great question. So we were looking at the bioimpedance, and then many of these I've also done a clinical exam, and I do notice less swelling in their limbs and legs, essentially. I really haven't noticed much change in this, less in the arms, but that's what we're, but no perimetry or limb volume measurements were done.
Thank you, Tom. Does anyone have anything else they want to talk about around kind of prescribing criteria and kind of where lipedema kind of sits in that? Jose, did you want to jump in?
Well, I would like to say some things about the GLP-1. First of all, that between the loss of weight by any papers is between 25 and even 50% of muscular mass. First. Second, about the inflammation, what you can get, when you can see what has been studied is inflammation in the normal obesity. But what about the inflammation lipedema cell, lipedematous cell, lipedematous adipocyte? There's nothing about that it responds. And in my experience, and we're beginning to speak in experience, I have received many patients that has been treated with agonist of GLP-1. They have lost weight, but in the half upper part of the body and very little in the down lateral part. What I think then, that the lipedematous adipocyte does not respond to this treatment. But I continue. About 15% of the patients with treatment with GLP-1, with an agonist, has the only one that continue after 2 years. About 70 or more, depending of the papers, they lose these medicines and they gain again the same weight that they lose, but in this time it's only fat. And that's a very big problem, very big problem. I continue. The positive effects about going down the pro-inflammatory cytokines, TNF alpha and other similars, has been studied in obesity people, but not in lipedematous people. I hesitate that the pro-inflammatory cytokines goes down in the adiposity of lipedema in the inflamed cells of lipedema, maybe in the obese cells, because they have obesity and lipedema. The part of obesity probably respond, but the part of lipedema, no. Well, let's continue. 2 more things. There has not value than the UCP1, that is very important for me, is down in lipedema, I think, but this has not proved. And other things that we are not validated in the use of the agonist of GLP-1 agonist is the change in the microbiota that you make. And this is very important because probably many changes and many will respond is due to changes in microbiota. And I will say more and finish. Our hypothesis is that sub-inflammation in lipedema is due to a leaky gut syndrome. And maybe that leaky gut syndrome will get better because you are not eating a lot. Thank you.
That's a lot there for us to go on with for sure. Gabriele, as somebody with a nutritional interest as well, did you want to come in at this point?
Yes, I've been wondering why it is that under GLP-1 RAs, people or patients lose that much more muscle mass than with other, say, nutritional interventions. I've been treating my patients for by now 17 years by a ketogenic diet, and then possibly with a less strict low carb diet to be followed by that. And I see two or three very important differences. Ketones reduce hunger. So patients feel well, they are satiated, there's no hunger. GLP-1 RAs reduce appetite. What's the consequence? GLP-1 patients feeling nausea on top of that, or because they feel nausea, they tend to eat the wrong food. By the way, in the patients that I've seen, I can't see a reduction of cravings, especially for sweets. They don't lose those cravings. So what happens is, on GLP-1 RAs, they tend to eat the wrong food. On keto, they tend to eat real food because I teach them how to eat real food. So I come back to that paramount aspect of, if you use them, and I do it, I think I start off the same as Tom. I treat all my patients, so I recommend a low carb to very low carb diet, real food and so on, no additives, and only if that is not working. And the trouble is, it works in so many cases that I just don't have enough experience with the GLP-1s. So it's only the desperate cases that I put on GLP-1s. But just to conclude, the patients on the diet lose as much weight in the same, even faster, in the same amount of time. I have a feeling it's more than because they don't rely on the medication, they rely on their own change of lifestyle and nutrition. So they lose as much weight and they lose it feeling much better. They haven't got nausea, they have great appetite, they eat what they have to eat or what they should eat, and because of that, not only their muscle mass is preserved, but their activity increases and their whole well-being. This is the one thing that they all tell me. They feel so much better. And I don't really think that patients on GLP-1 RAs or GIP would tell you that they feel so much better, at least not during the first few months. Thank you.
Do you want me to come back, or we have questions? What?
Why don't you come back on what Gabriele was saying? And I know Jose would also like to jump in, but if you could come back on what Gabriele's saying, and then I will pick up a couple more questions for us to discuss, if that's okay. So Tom, do you want to jump in first?
Well, I was going to respond to Jose, but that's
sure,
okay.
Go for it. Respond to both of them.
So I think that I want to dial on this loss of muscle mass, because I do think there is an absolute, anytime you lose weight, you're going to lose muscle mass. I think, on the studies have shown through bariatric surgery, through weight loss diet, and with these GLP-1s, you lose about 20% of your muscle mass. I am not aware of these studies showing greater, like 50% muscle mass loss, because I do know, I have a couple slides pulled up, or I could, if you like. There was a study by
Go for it, Tom. Feel free.
Well, let me see if I can share this. Just a second here.
Just while you are searching, it's certainly not necessary to lose as much muscle mass on a keto diet that really looks after your protein intake and so on. And I have this experience.
So I expect, I don't know and I'm interested to know if you have if anybody's, but I expect it's similar to others. But I do say that, and this is part of my thing is to increase resistance exercise while they're on these GLP-1s. I was going to point to this. I don't know if you probably can't even see it, but Ann Brennan, they basically added this study. This is not lipedema patients. This is older obese patients. They added 60 minutes of resistance training to them, and they were able to preserve the normal 20% muscle mass loss. They decreased it to 2% from less than a kilogram from average normal 9 kilograms were lost, and they lost only about a kilogram of muscle mass when they added that resistance along with their weight loss. So I mean, again, this is another opportunity to stress lifestyle measures and that they should be doing that. And again, like to your point, Gabriele, and I think it's so well you said it so well, is that they if they're eating real food and I know you and Dr. Simarro disagree with me, but I think that all hunger goes down, and if they are directed towards those nutritional things, I think it could be an aid to better nutritional habits. But that's my hope, anyways. And okay, I'm gonna stop my share. Thank you.
That was lovely. Thank you. I think Jose wants to jump in. Jose?
Can I tell you something? JAMA, volume 332, number 16. Weight loss, induced muscle mass loss. William Evans and of year 2025. The Lancet, Muscle Matters, the effects of medical induced weight loss on skeletal muscle. Metabolism, effect of glucagon-like peptide-1 receptor agonist and co-agonist on body composition, systematic review and network meta-analysis, March 2025. All them says that the muscular mass weight is between 25 and 50. These 3 papers. Sorry, because my camera can unfold.
No, it's fine. So they're reporting 25 to 50%. I'm familiar with the 20 and 25%. I am not familiar with that 50%.
Well, it's probably not muscle mass. I mean, lean mass is not muscle mass. Lean mass is a loss of total body water and extracellular water and so on. So one must differentiate.
In JAMA, September 2024, the loss of skeletal muscle mass is poorly described and has not been measured for weight loss. The figure 50%.
Thank you.
And it's published in JAMA in 2024. So why is that? Because if you just prescribe to your patients GLP-1 agonist and don't say him, you have to go with the nutritionist to increase the food of proteins and to make exercise, then they will eat whatever they want. And what do they usually eat? Not proteins. Not proteins. Do they make exercise? No, because those people that are obese, many times because they don't make exercise. They have not to make exercise. They have not to change the way of eat, so they will lose a lot of fat mass. But later, at the end, I want to speak with something that nobody has to speak here about, the positivity of GLP-1. So at the end, please give me 5 minutes and I will speak of something that nobody has spoke before in lipedema.
So thank you very much, Jose, and dear Tom. I just want to go back from the side effects to the effects. When we are talking muscle mass, there's a question of side effects, and might be or not, and surely they have to take proteins. And I believe my patients do what I want them to do, mostly. But let's point out again, since decades, we are telling you can't change the lipedema condition and remove it by diets and sports. It's written in every textbook, and it's quite common knowledge. Maybe it's totally wrong. Maybe it's totally wrong. I don't believe it. But just go to the GLP-1s. You gave us one paper, one slide in your presentation, that these medications works by influencing the appetite regulation and glucose metabolism, helping managing obesity and other related conditions. So again, I want to know, is this the new modern drug against lipedema, even in America, where you can sell it in any corner around? Or can we really underline and give the hand that this stuff is a medicament against lipedema? I'm not discussing the judge. I'm not discussing the indications by the companies who sell this stuff, but indeed they say it influences the appetite regulation. And I would like to have an idea from you, what is the appetite regulation to do with lipedema and all these questions we are around? For me, these are two very different things.
Yeah.
Maybe you have an answer, maybe not. We go on discussing in the next years. Okay, but maybe you have an idea.
Well, yeah. I mean, again, we're not saying there is an indication. I think I mean, I don't know. The answer is the jury's out. We don't know if this will specifically help the patients with lipedema. In my experience and the experience of my patients, they have reported improvements, but you know, again, there's so many more questions around this than there are answers, and it could not be related to anything specific to the GLP-1s. And maybe this is just I mean, it's possible that this is just a tool to reinforce lifestyle changes, but or tell them that they need now to increase their resistance exercise, and they need now to really decrease their refined carb, and then that will help them. I can't say for sure that that's not what's going on.
I'm going on this point because I know when you publish this paper with these small amount on patients, and you will write in the paper, we have a small amount of patients, and this is a weakness of this so-called study, which is not a study, it's just where your experience is written in the paper. This will go into the internet as quick as you can look after this. And the first bubble of patients will say, oh, there is a doctor in US and he gives us the idea it could be possible. So we go on to buy this directly in the next pharmacy. In Europe, it would be in Netherlands to buy it, and we take this drug. I think as LWA and as well as research, we have to be very careful with giving us dealing such informations. We have to be very careful to say, stop it. It's not free to do it for everybody. If anybody takes this stuff only with a medical condition, a doctor on my side who looks for all the effects and the side effects, and maybe the doctor says, this is the wrong medication for you, stop it immediately. Because I have the fear that we give advice to, this is the new miracle drug on anything,
Yeah.
I know this hysteric discussion in lipedema all over the world. And I understand quite these discussions of the women which have this disease. They want to have a solution. But the solution might be, for a very small portion of all these patients, might be this stuff. And we can talk on this when we have good clinical studies and not your very well done expertise. This is my fear. As LWA, we have to have a very good view on these questions.
I'm going to come in, if I may, at that point, Tom. I think it's really interesting looking at that perspective, isn't it, Manuel? I feel like it reflects a little bit about what I heard when people were talking about whether lipedema reduction surgery or liposuction would become ubiquitous, and would patients go to that rather than taking other interventions. What else may they need to adopt as other lifestyle changes to maximize the benefits of that? And I feel that sitting here kind of as a patient representative, there's a lot of similarity in some of those early discussions. And I wonder whether some of it is whatever happens when any new treatment modality is explored, that we have to find the evidence base to make the recommendations suitable, in order to find that optimal patient population for any kind of treatment. And that's where I think it's interesting, where we've got yourself talking, Tom, from a very wide range of practice perspectives, and the experience that, say, Gabriele and Jose have around really working nutrition for patients. And it's definitely important to balance those aspects.
Yes, yes.
We've had a number of people picking up on a little bit around reducing inflammation, and I feel like it might build on what Manuel was saying, Tom, which is you talked about kind of that, you talked a little bit about those anti-inflammatory aspects, because you're talking about IL-6, and there are people kind of talking a little bit about saying, well, actually, GLP-1s are having an impact on fibrosis. So there is something going on at a kind of more biomechanically, there's something taking place which may be a beneficial effect separate to any kind of appetite-based impacts.
Sure.
And I think that's something where we don't really see any papers that I'm aware of that say in patients with lipedema.
Right.
But would you like to just recap a little bit on that, your perspective, perhaps, Tom, and then anything the others think on that?
Well, again, we don't know about lipedema. We do know there's decreased fibrosis and inflammation in the cardiovascular, like, for example, in epicardial fat and hepatic fat. We are, that was just drawing parallels, but again, there's no proof of that, but it is certainly possible that those same effects are being experienced in lipedema tissue.
Thank you, Tom. I know, Jose, you'd said there was some positive things you wanted to say that we haven't touched on. Did you want to bring those up now? Because then I know there is a question in the chat which will link to something that you were talking about earlier around eating disorders. So before we get to that, would you like to jump in with your positives?
Yes. I'd like to speak better English to express what I will say. We have speak about the GLP-1, but we have lose one very important thing. In our experience, but not only in our experience, lipedema goes with behavioral disorders, with eating disorders. Why? We think, and it has been described in later papers in this year and in 2024, that the hypothalamic system has neurons, PONCCET, that gives satiety, and other neurons that gives hungry. When you're inflamed, the satiety center doesn't work, and that's why you eat much than you should. the hypothalamic center of satiety doesn't work when there is inflammation. Then it's very common in our experience that many patients says that they are hungry even they eat good if they don't have a carbohydrate refined. And why? And that's bread and that's sugar. They eat by, if they don't have bread of sugar, they don't feel that they has eat alone, because the hypothalamic inflammation makes them to be hungry of more things. Why? Because when you eat an hydrocarbon refined, the glucose goes very high in the blood for a moment. Then the hypothalamic center that is not working, in that moment it works and you feel satiety. So women with lipedema, we have a new question in our test and says, do you usually to feel better after it or during it, you have refined hydrocarbons? Because if not, you feel not very good. And they say almost 70% yes. Because the satiety center only works with this peak of glucose. Then they begin to eat hydrocarbonates as bread, as sugar, very usually. And that makes a compulsive attitude with the bread. But in ketogenic diet, due to beta-hydroxybutyrate, the satiety center works again, and they respond to leptin that usually don't respond to leptin, because leptin works in the hypothalamus. But if it's inflammatory, leptin doesn't work. That's why they don't feel hungry with the ketogenic diet. With GLP-1, it's the same. They make that this center works, but it's not continuous. You need to have it. Then you have to change that compulsions with the time, with help of the psychologist. So it's very important to study in the future about the hypothalamic satiety center and the problems of this center in the lipedema, because if you stop that inflammation, they will not eat a lot, and especially they will not eat so much bread and sugar. Let's study about that. Thank you.
I think there's broad agreement with a lot of what you're saying, Jose. Something that we haven't explicitly touched on, but I know you had thought about, Jose, was about patients with eating disorders. And I know that's come up a little bit in the chat, which is if one of the ways in which GLP-1 receptor agonists can benefit some people is an effect of appetite suppression, there are some people with opinions about the prevalence of eating disorders in lipedema. And I would like to just get some opinions from a few of you around balancing those two aspects in people with lipedema, around perhaps orthorexic eating disorders, and where this kind of medication may fit with that. And I feel probably a few of you might like to comment, and I guess, Jose, you'd like to start?
There are papers published about that. And it's the beginning. There are papers published about the GLP-1 and the satiety center and the behavioral disorders. I have found 3, I can tell you exactly why, but it takes time. 3 or 4 papers about that. But maybe the most important is I read you exactly. Give me a minute. GLP-1. Oh, it's super terrible when you want to find
It's okay.
something.
What we can always do, Jose, is we can when we on our website provide some
This is
references
I found it.
we can link. Oh, you've got it.
I found it.
Perfect.
The impact of glucagon-like peptide-1 GLP-1 agonist in the treatment of eating disorder, a systematic review and meta-analysis. This is from 2025. Do you know that at this moment the GLP-1 agonists are using, in United States, there is a paper published that they give it to in Alcoholics Anonymous. Do you know that they goes down to they eat, well, they drink 40% of alcohol than before? 40% they drink. There are studies beginning about the smoking and the GLP-1. So I repeat, the impact of glucagon-like peptide agonist in the treatment of eating disorder, a systematic review and meta-analysis. This is published in January 2025, and I can tell you 18 and weight disorders, studies of anorexia, bulimia, and obesity. And it's in Springer. I told you, read that. It's very important in lipedema.
Thank you, Jose. Does anyone else want to come in on the particular topic around eating disorders or other factors and how lipedema in particular plays into that? Gabriele?
Well, I just think it's important to be aware of the high percentage of eating disorders in lipedema patients. If we in the wider sense of eating disorders like restricted eating and so on, and that's always a challenge. Even, I mean, for a nutritionist, the same. I suppose one has to be aware of the risk of them falling back into. And actually, I don't know this paper, Jose, but I would not like somebody who was anorexic to lose their appetites. I would like them to learn how to enjoy their food, how to develop a positive relationship with their food. That's what we try and do as nutritionists, don't we? So I see a risk, but I don't. I have patients, lipedema patients with a history of eating disorders who I have treated by a nutritional intervention, but I haven't had any who are treated with GLP-1.
Thank you, Gabriele. I think it's a difficult topic.
Six patients with eating disorder after the treatment with GLP-1, and all of them, they was not very. They was they were obesity or overweight, not of course in teeny people, and they continue for 6 months is the one that is more longer, and 3 months, 4 months the other, and they are not, after losing weight, they don't gain again weight.
I appreciate this is a topic that probably we could continue to discuss, and I hate to draw the conversation to a premature close, but I am mindful of time and that we have been running for around an hour and a quarter, and I think it's testimony to the fact that we came into a conversation saying, in a sense, there's a small amount of anecdata, if you like, of kind of clinical experiences like that, which Tom has generously shared with us and Gabriele, and a small amount of published papers. So I appreciate that we've managed to do so much, and we could keep talking. But I think we probably, in the interest of time, ought to draw it to a close. And some of those other papers you shared, Jose, we'll do a little write-up around this evening, and we can share some of those other paper links on our website, particular ones from you and from Tom. Is there anything else anybody would particularly like to say before we draw this evening's session to a close? Manuel?
Thank you very much. Great session. Good ideas. And we move on. And keep calm.
Especially to Tom.
Yes.
Please don't.
Thanks, Tom.
I mean, we all appreciate that you started doing something. I mean, there were critical questions, and I don't want you to leave here feeling, oh gosh, they criticized me. It's great you started it, and I think we have to do more of this sort.
Yeah.
Yeah. Yes.
Thank you. This was wonderful, and I really appreciate the discussion and and the opportunity to share what the very, very early stuff. But I think this is, thank you for everybody.
Yeah, you've been very kind, Tom, to let us all pick over your early data, and I appreciate you and everyone else joining in to discuss the different perspectives. Obviously, if any other of our founder members or other members want to do similar experiences, I'm sure we're very happy to share other people's data and papers and bring these kind of perspectives to it, because this is what the Lipedema World Alliance should be about: exploring topics and questions where we have limited understanding and a lot of questions, to see what, as Manuel said, where we can take what the perspective should be, what the recommendations are, and how to move forward when there's a clamour of patients wanting to know, what do I do today in a situation with limited guidance? So I'd like to thank everybody on the panel. It's wonderful in the Lipedema World Alliance to have so many different perspectives and to have people from so many different healthcare systems making us what we are. We have founders from over 20 different countries, so a lot of different healthcare systems and setups, as is evidenced by the 4 we've touched on a little tonight. So this video will remain live on our YouTube channel. You can watch it back, so when you want to catch exactly which papers Tom or Jose referred to, you can zoom up and down to get those. And we look forward to sharing more information with you on our website, lipedemaworldalliance.com, and meeting many of you in Rome at the Lipedema World Congress. And if you want to know more about that, you can find out more in the video that we had earlier on our YouTube channel on the 13th, I think, if I remember correctly. So thank you ever so much, everybody. And we have appreciated very much taking this discussion forward. And I can't wait to be back together again when we have even more and when Tom's published his latest data. So thank you very much, everybody.
Thank you.
Good night.
Good night.